Yes. Yes. Sanya, please go ahead.
Thank you, ma'am. So, today evening we'll be discussing the case profile of a 14-year, 9 months old girl who was admitted with us in June 2019 with complaints of absent secondary sexual characteristics and poor height gain noticed for the past 5 years. So, coming to the briefly to the details of history, she was a term AGA child with smooth perinatal transition. Apart from that, she had history of prolonged neonatal jaundice. She had received phototherapy for nearly 12 days. Subsequently, she was discharged and remained well. The baby was quite well till 10 years of age when parents started noticing that she had poor height gain. Initially, they were going to local practitioners who mainly gave them reassurance, and finally, they landed up at PGI with us at the age of 12 years 4 months. However, there was no history suggestive of any CNS infections or head trauma. She was a developmentally normal child. There was no history suggestive of any past recurrent illnesses or hospitalization or systemic illnesses or history suggestive of DI. So at that time, we evaluated the child on OPD basis. She was found to have short stature and a delayed bone age. Her routine investigations like the hemogram, RFTs, and electrolytes, celiac serology were all normal. So we went ahead with the hormonal profile, and it was found that she was found to have central hypothyroidism, for which she was started on levothyroxine. She was planned for further workup. However, unfortunately, she was lost to follow up, and she didn't come up again in the clinic. Finally, at the age of 14 year 9 months, the family again turned up with us, and with this time not only with the complaints of poor height gain, but also with the complaints of absent sexual characteristics and no having not attained menarche. So this was all about the history. Uh, so coming to the examination at 14 year 9 months of age, so she was admitted and we re-evaluated her. She was again, so again we found that she had short stature and the height was nearly minus 6.34 let's go. This is as per the IAP 2015 growth chart. Her growth velocity was quite less, that is 2.9 centimeters, 2.19 centimeters per year. Here we can clearly see that in this growth chart, this is the mid-parental height, and she is. This is at 14 year 9 months of age. We can see that she is significantly lacking behind her growth or genetic potential of growth. Moving on to the further examination, she was found to have stable vitals. The general physical examination showed she had mid-facial crowding with prominent forehead and immature faces. So there were, however, there was no stigmata of Turner syndrome, like no weakening of neck, multiple nevi, or low posterior hairline, cubitus valgus, etc. She was not found to have any kind of midline defects or any anomalies. The SMR staging was suggestive of a prepubertal child with breast stage 1 and her pubic hair and axial hair were absent. And the systemic examination was essentially normal. So to summarize the history and examination, we have a 14 year 9 months child who had presented with poor height gain, absent secondary sexual characteristics. She was being treated for central hypothyroidism, had history of prolonged stature with immature facies, no anomalies or no Turner stigmata. She was a prepubertal child. So, so looking at the history and examination, though she did not have any Turner stigmata, but any child presenting at 14 year 9 months of age who is girl and had poor height gain with absent puberty, so first differential we would like to keep as Turner syndrome. Although another differential here we would like to keep is the combined pituitary hormone deficiency, which could be either congenital or acquired. So we went ahead with the further
Sanya.
investigations.
Sanya, are your slides
So,
moving?
so the baseline investigations were normal. She had normal human.
Hello, Sanya.
Hello. She had.
Yeah.
Yes, ma'am.
Sanya, your slides are not moving.
Okay, ma'am. Let me check, ma'am.
Yeah, sure. Would you like to reshare? Because I think you've gone out of sharing mode.
Yes, ma'am. I'll share it once again because.
Yeah.
So, ma'am, are the slides moving right now?
Yeah, absolutely.
Okay. Should I continue with the
Yeah.
investigations or should we stop for a?
Just continue. No, continue, please. Yeah.
Okay.
Yeah.
Thank you. So moving ahead with the investigations, the baseline investigations again done were normal. The ultrasound pelvis done here showed that she had a uterus of 2.5 centimeters. The ovaries were obscured by the bowel gases, and the ultrasound KUB was normal. So
Go ahead. Yep.
yes, ma'am. So the bone age was much delayed. She had a bone age of about 7 years at 14 9 months. The hormonal profile showed that she had normal TFT. However, this was on the levothyroxine of 25 micrograms OD. The growth hormone baseline levels were low, that is 0.03. Her cortisol was 96 and low LH and FSH levels. The prolactin levels were also low, that is 4.5 nanogram per ml. So we went ahead with the growth hormone stimulation testing. To test both the X's, we did insulin tolerance test, and we found that the growth hormone levels were not stimulable. So the maximum levels we got could found were 0.03 nanogram per ml. And also for the cortisol, the axis we found that she had secondary adrenal insufficiency with maximum stimulable level of 316.6. So for delayed puberty also we did the GnRH analog stimulation test. It was done with triptollerin 100 microgram per meter square, and it was also found to be not stimulable. The peak stimulated LH levels were 0, 0.8, which was consistent with hypogonadotropic hypogonadism or gonadotropin deficiency. And the neuroimaging was also done, which was suggestive of empty sella with non-visualized infundibulum and ectopic posterior pituitary brainstem. So, after all these investigations, if we look back at our initial possibilities, so we have kept one possibility of Turner syndrome on the basis of history and examination. But after investigations, we can actually rule out this because we did not see any hypoplastic uterus. The LH and FSH was suggestive of and the gonadotropin stimulation test was suggestive of hypogonadotropic hypogonadism, and we found an obvious defect on MRI. So for CPHD, everything was favoring, and a diagnosis of CPHD was considered upfront. So our final diagnosis was delayed puberty, hypogonadotropic hypogonadism, secondary hypothyroidism, secondary adrenal insufficiency, short stature, which was secondary to, and all of this secondary to combined pituitary hormone deficiency, secondary to a structural pituitary defect. So briefly about CPHD.
Sanya, uh,
Yes, ma'am.
there is a background noise coming from your computer, like internet message. Can you just check that and dismiss that? Maybe like a ringing noise. Yeah. Okay. We'll just go ahead then.
Is it because of the alerts of messages?
Alerts of the internet that the connection is not stable.
Okay, okay.
Let us just go ahead.
Dr. Sanya, can you just refresh? I think so now it's fine.
Now it is better. Yeah, we'll go ahead.
Sure. So very briefly about CPHD. CPHD or combined pituitary hormone
You need to
deficiency.
share again. You need to share again.
Oh, okay. Sorry for the inconvenience. So, is it visible now, ma'am?
Yes.
Hello.
Yes.
Yes,
Okay.
Anuj.
Sorry for the inconvenience. Continuing with the discussion part. So, CPHD, very briefly about this. CPHD is basically when we call it as CPHD when two or more pituitary hormones are affected. The reported incidence is about 1 in 3,000 to 4,000 live births. The clinical features may vary in severity and the time of presentation. Onset may be in the early neonatal period or even in later life, depending upon the severity of presentation. And regarding delayed puberty, nearly 20% of the cases of delayed puberty in girls and 10% in boys are caused by congenital or acquired defects of the HPA axis or CPHD. So CPHD can be classified depending upon etiology into the congenital or acquired causes. The congenital causes are caused by a whole lot of genes, defects in a whole lot of genes like HSX1, GLI2, GLI3, SOX3, SOX2, and a lot more. So acquired CPHD can be caused by numerous causes like neoplasias, infiltrative disorders, infections, non-neoplastic radiotherapy, and or head trauma. So in the index case, as the history was not suggestive of any CNS infection or any significant trauma or radiotherapy, and even the imaging was not suggestive of any acquired cause or supracellular mass, so the acquired causes could be ruled out. So we kept a possibility of the congenital CPHD in the index case. So for the diagnosis of CPHD, we need a hormonal workup for where we assess the various hormones of the HPA axis. So all this was done in the index case. We did the growth hormone stimulation test, DNRH stimulation test, and we found that the index case had growth hormone, gonadotropin, TSH, and ECK deficiency. The second step is neuroimaging, and all the patients with documented hypopituitarism warrant an MRI, as was done in the index case. And the third step for the diagnostic, definitive diagnosis is the genetic testing. So the genetic testing in CPHD can be guided by the MRI findings, hormonal deficiencies, or the extrapituitary features. There are a lot of syndromes which are associated with CPHD. Here, I have in this table, I've highlighted a few of them which are like commonly reported, like HSX1, which is associated with septoptic dysplasia, PTX2 with Reiger syndrome, GLI2 holofrozencephaly, GLI3 with Pallister-Hall syndrome, SOX3 with which is associated with mental retardation, and SOX2 with microphthalmia and anophthalmia, LHX3, LHX4, and OTX2. So LHX4 is associated with hypoplastic anterior pituitary, ectopic posterior pituitary, and thin or absent stop. There may or may not be cerebellar anomalies in this case. So after scrolling out the list of these genetic syndromes and the genetic defects, the closest differential which we could found to in our index case was LHX4. Although she was not fitting in any of these completely, but the closest differential what we could keep is the LHX4. So the final diagnosis in the index case, what we can point out so far is CPHD, which is a congenital cause. However, we require genetic testing for confirmation, which unfortunately could not be done in the index case because of the financial constraints. So moving ahead with the treatment part. For treatment of CPHD, the mainstay of is the replacement with the appropriate hormones. So the hormonal therapy is being at the growth hormone, the sex steroids for the hypogonadotropic hypogonadism, levothyroxine for secondary hypothyroidism, then hydrocortisone. For prolactin, we do not need any specific treatment, and desmopressin for the ADH deficiency. So I'll tell about the index case, what all she was started in the subsequent time. Very briefly about the hormone replacement in hypogonadotropic hypogonadism in the females. So, estradiol therapy or estrogen therapy is the mainstay of treatment. The treatment has to be started with very low dose of estrogen, and it has to be built up to the maximum doses over a period of 2 to 3 years. So, the induction should be carried out over 2 to 3 years period. So the latest recommendations say that 17 beta estradiol is preferred over other synthetic estrogens. This is probably because the assays are easy with this estradiol, and it is more physiological to be used. The dose has to be given an OD dose before sleep each night. So the 17 beta estradiol, the starting dose in the first year is about 5 mics per kg per day, and we gradually build up the dose every 6 monthly to a maximum of about 20 mics per kg per day. However, the girls with short height, like severe short stature, height less than -3 SD, at the start of induction should be offered an extra 6 months of 7.5 mics per kg per day between the year 2 and 3. The maintenance therapy reached in the fourth year is approximately between 1 to 4 mg per day. So, beside this oral therapy, the transdermal patches can also be used. The starting dose is around 3 micrograms per day to a maximum ranging from 25 microgram to 100 microgram per day. Progesterone is definitely to be added. The latest recommendations now say that progesterone should be added on the basis of the ultrasound uterus findings that the uterus and uterine endometrium is thick enough, and on the basis of which the progesterone should be added, as compared to the previous beliefs that it has to be added preemptively either after the 2 years of estrogen therapy or after first time when the breakthrough bleed occurs. And the progesterone formulation which can be used is the progesterone acetate 5 to 10 mg for 10 days each calendar month. So the treatment in the index case, for central hypothyroidism, she was started on levothyroxine. For secondary adrenal insufficiency, she received hydrocortisone 10 mg per meter square per day. She was started on growth hormone at 25 mics per kg per day. And for delayed puberty, the family was counseled and they were planned to start, and she was planned to be started on estrogen therapy on follow-up. So the last slide on follow-up. So she received nearly 10 months of growth hormone therapy. She attained a good growth velocity of nearly 8 centimeters per year. We can see this was the prior growth hormone period. So this was the catch-up when she received the growth hormone for about 10 months. However, due to financial constraints and this COVID lockdown, the financial condition of the family was bad and they had to stop growth hormone. And subsequently, again, the growth velocity declined. And she was again lost to follow-up since after 15 year 8 months of age, and estrogen therapy, even after repeated counselings, that the family refused this therapy. So we call them to check the current status of the child. So currently she is 17 year 2 months of age. She is off growth hormone for nearly 15 months. She is getting levothyroxine and hydrocortisone, and family is still not willing to start the estrogen therapy. She is quite short, nearly minus 5.16 the score, and the SMR staging is suggestive of a prepubertal child.
Right. Yeah, sure. Sanya, please continue.
So the key messages here are in a girl child who is presenting with short stature and delayed puberty, though Turner syndrome is the first possibility, but we should also keep other possibilities like CPHD back in the mind. For CPHD, the genetic testing is guided by the hormonal deficits, the pattern of extrapituitary manifestations, and the neuroimaging findings. So, for the hormone replacement therapy in the girls, 17-beta estradiol is the recommended form of estrogen to be used for HRT. And it has been now recommended that addition of progesterone should be guided by uterine maturation on ultrasound rather than the duration of estrogen therapy or breakthrough bleeding. Thank you.
Thank you. Sanya, thank you for your presentation. Maybe we could just put together some key points for a discussion that might need to be highlighted to just sort of put across the complete clarity on the case capsule that you've captured so very well and so effectively. I think I would just kind of like to suggest that when we are looking at the initial presentation, which is our history and just clinical examination with very simple tests like a bone age, a child who presents at 12 and a half years of age with short stature and sexual infantilism, as she did at the initial presentation, with a bone age of 6 years, a delay of almost 6 to 7 years of bone age from chronological age would make me very worried to think about Turner as a possibility. Though in a girl child, you would always want to consider that and exclude it for the sheer commonality of the problem that we are dealing with. And of course, the whole sort of management principles are going to be so extremely diversely different. Having had the thyroid functions, I think you were fairly one up in the entire process of understanding that you are dealing with a very discordantly low T4 and inappropriately high normal TSH and that itself told you that you were dealing with secondary hypothyroidism. And in that context, if I just continue, your treatment with 25 mic, as you put down on this particular slide, for which the monitoring is being done, I would think that her monitoring, I'm kind of little worried about it in terms of adequacy of managing her thyroid status. I have a patient who is diagnosed as secondary hypothyroidism and started on levothyroxine regimen. First thing that I would like to do is set my goals right. And my goal would be to look at the free T4
Yes.
as my index of monitoring her, because it's very, very hard to monitor her on total T4. And
Yes.
second important caveat in this entire sort of investigation would be that TSH will not be more than zero point 0.5, preferably zero point 0.5, never more than 1 in a adequately replaced secondary hypothyroidism. So that kind of makes me little concerned and little worried, and I would be careful about it. And I will make sure, as a logistic part of it, that the blood collection is done before the morning dose of thyroxine is done, because that can raise your levels by maybe 20 or 25%, and we need to be careful on that particular front as well. I do see the fact that your cortisol has started going down, but cortisol is one hormone where it shows huge degrees of fluctuations. So I would be very careful about that part of making diagnosis on basal cortisol. But of course, you've got a stimulated value as well. And just one more note on hypothyroidism, you will notice very clearly that your child clinically on her faces, on her skin, and on her lovely smile
Yes.
barely looks hypothyroid.
Yes.
Barely. I mean, and that's so typical of secondary hypothyroidism. The simple masking of the symptom complex, or very subtle and very mild symptoms with which they present, is something very remarkable about these young children, or even adults for that matter, is something that we need to kind of put across in our head when we are dealing with secondary hypothyroidism, unlike primary hypothyroidism. So cortisol was second thing, which of course needs to be addressed. And I do see the fact that your cortisol earlier was normal. So
Yes.
very happily you could start the child on thyroxine alone as a replacement, as a management strategy, because I would be worried and I would continue to monitor my cortisol, which is what you have done as well in this particular child, and shown in the next slide that this child definitely has on insulin stim test, deficiency of both growth hormone and cortisol. I would be scared of insulin stim test in this particular child, because I'm now looking at somebody who's got central hypothyroidism, and I'm worried central hypothyroidism as an isolated finding is extraordinarily uncommon. So I'm immediately setting a stage for multiple pituitary hormone deficiencies. And in that kind of a scenario, putting the child through insulin stim, and I'm sure you were monitoring her very effectively and
Yes.
closely. We as an institution had stopped doing insulin stim tests, I think now more than 10 or maybe even 15 years ago. I kind of don't have that recall, but I would be very cautious about using this particular stimulus to look at my growth hormone status, provided I have looked at adequacy of thyroxine replacement, which I have not documented. I would be worried about that part of it. I would be worried that the cortisol replacement has not also not come on board when I'm looking at growth hormone stimulation. And of course, sex steroid priming is something that I would look at in that particular child to delineate my growth hormone status better. Having said this, though these are something which can change the performance of your test, I think your growth hormone status is so poor
No.
that it is
Yes.
not likely that you've gone wrong, and your diagnosis of growth hormone insufficiency.
you stop sharing the screen, Sanya?
Sure, ma'am. I'm actually not
Yeah,
here, ma'am.
I think Dr. Nalisha's connection has lost.
Yes, ma'am.
So we are running a bit late.
Yes, ma'am.
There's a number of questions in the chat box actually.
Yes,
I think Sanya, if you can look through them and answer a few of them that you can, anything related to the case, that would be great. I think
sure,
we
ma'am.
may have to move on to the next session. Dr. Sheila?
I think we could take a couple of questions.
Sure.
The difficult ones, and most of the questions Dr. Nalini has actually
Yes.
answered.
Yes.
Yes, ma'am.
How sure, Dr. Vijay Sarath is asking, how sure are we about diagnosis of hypo in this girl at this early stage? Can't this be just a reflection of severe growth hormone deficiency?
Ma'am, but we did the tryptophan stimulation test, and LH was the stimulated LH levels were quite low. So the stimulated LH levels were only 0.8. So that is less likely to be in just ICHD. So that can reflect hypogonadotrophic hypogonadism in the index child.
And again, from Dr. Vijay Sarathi, what is the role of GNRH stimulation test in the routine diagnosis of hypo?
So, though it is very difficult to differentiate between CGTP and hypo on the basis of this tryptophan or the GNRH analog stimulation test, but the latest textbooks and the latest literature says that if the stimulated LH levels are less than 2.8 in the analog stimulation testing test, so that is pointed towards hypo rather than the CGTP. Obviously, we have to look about the other things like the bone age is much delayed in all this scenario, which could not be there in CGTP. And we can even look at the inhibin levels, which was obviously not done in our case because of the financial constraints that's not being done in the institute, and we could not get it done from also. So these a collaboration of all these findings can happen.
Yes, ma'am. For a while, we have lost you there.
I'm sorry. Yeah, I'm sorry. I think I'm lost, and I think we are. Sirisha, would you agree we are running behind time?
Yes, ma'am. We just took a couple of questions.
So,
if it is okay with you, if you could just clarify many questions actually in the chat box, that would be excellent actually, because
sure.
many interesting questions.
I would kind of do that, but I think there is one thing which probably Sanya could help us is that the MRI, the way in which it is done. I think in postnatal stroke interruption syndromes, you have to be very, very careful because these are children and you don't want to subject them to gadolinium as a contrast medium. That there are concerns which are being raised, including warning from FDA. So you want to be sort of looking at a possibility of T2 drive related sequences putting together the PSIS as a syndrome. So I'm just going to take some questions, Sanya, that
initial couple of questions I've asked.
Okay,
but
lovely.
We are just
so I would think, Sirisha, because I'm lost in the sequence, would you continue asking?
We'll just take 2 more questions, ma'am, in want of time.
Sure. So if there's a question, yeah, please go on, Sirisha.
How do you decide whether to give 1 or 2 milligrams of 17-beta estradiol as a final dose in hypogonadal girls?
So, the recommendations say that initially when we are building up the doses, we do not have to do the estradiol levels. But when we are almost reaching the 4th year, then or we are reaching the maximum doses, then we can do the 17 beta estradiol levels. So, if depending upon those levels, we can titrate the maximum dose. That it can be anywhere from between 1 to 4 mg, depending upon the sensitivity or the response of a particular child. And the levels of definitely on the levels of 17 beta estradiol in the 4th year.
And from Dr. Rajni, with yes.
What do you say, Dr. Nalini, is the dosage?
So basically, I think what Sanya is alluding to is a final dose, which can rest between 1 to 3 milligram in adults, right? And there is really no easy way to figure out whether it's 1 or 2 or 3 milligram that you are talking about. That should be reflecting the adequacy of the replacement, really. And it's very hard to do the serum estradiol levels in a oral regimen when you're working with it. Transdermal is much better suited for it. There are definite studies which are available for it. But for the oral, the studies are very, very challenging because there are so many compounds which are generated which interfere actually with the 17 beta with estradiol estimation. So it's not very clear whether you kind of stop at 1, 2, or 3 milligrams. Typically, when you're going for a fertility related management, you need to kind of build it along the size of the uterus. That's very, very important biological marker that is being used. But other than that, based on the blood parameters, though it is proposed, it is not something which is very well put together in the literature. But that's not something that we do in clinical practice. We stop short at 2 milligrams.
Yeah,
Thank
thank
you,
you.
ma'am.
Last question. Ashu wants to know, Dr. Nalini, ma'am, any test other than ITT that can be done to diagnose hypocortisolism, as basal level of cortisol are not very reliable?
Sure. So basically, basically, I think I would try to say that ITT is something that I get a little scared about because of obvious reasons and so on. And even short synaptin stimulation test can be used as a marker of secondary adrenocortical insufficiency. And that is what people use all the time, including sort of literature publications, if you notice very carefully, in all the literatures of CPHDs, really speaking. And these are either 30 minutes or 60 minutes. Again, consensus sort of doesn't exist for that. And people use slightly different cutoffs in 30 minutes versus 60 minutes. Like 30 minutes, they would kind of use anything from 20 to 22 microgram. And in 60 minutes, they're using something like 18 microgram. Again, a word of caution here, because when you are doing cortisol estimations, and especially on automated assays, you're measuring a lot of compounds which get measured as cortisol. So there is a discrepancy of assay system based output. So typically on a Roche sample, if you use it, the same sample will give a lower reading. So the cutoffs now are being revised to the lower number when you're using Roche as a system versus other systems. So that tends to be a bit of a gray there, but the short answer would be use synaptin stim rather than ITT as a marker of secondary adrenocortical insufficiency.
Thank you.